Good morning to everybody. I'm glad you are here. We're going to continue this morning with the analysis and study of cephalometry. The importance of knowing cephalometry for the orthodontics, because what we have to do is scientific orthodontics that is based on evidence. That evidence that helps us make fewer mistakes. Science provides us with elements to make fewer mistakes. I was telling you that anyone who does something is subject to make the mistake. I was telling you that anyone who does something is subject to hit or miss. Whoever says that he has never made mistakes is that he has never done anything. We will always be subject to error. What every scientist seeks is to reduce his error, and if he can reduce it to 5%, he's already basically
complying
with a fundamental principle that is primum non nocere, which is a basic principle in every doctor. First, do not harm. You know you are going to make a mistake, right? But you reduce the risk. By reducing your risk, your success rate increase. And for that, it is necessary to have a valid information so that you can make correct decisions. That is what this course is about, that you have correct information available to make decisions that do not harm the patient. Very often in orthodontics, we make decisions based only on the buon senso. That is to say, in good judgment, in the good sense of things. I do not think. I have a hunch, right? And that's not right, because you can have a good intuition, like female intuition. What a doubt, right? But that cannot be all. Your decision has to be based on evidence. And the evidence is given by the analysis, and from the analysis, you make decisions. Cranial deflection measures the behavior of the skull base and its impact on a nasomaxillary component and the cervico-mandibular skull. At 9 years of age, the cranial deflection should be 27 degrees, plus minus 3. What does this indicate? What does this indicate? The minimum will be 24 and the maximum will be 30. What does this tell you here? That it has a cranial base within this mesocephalic branch. It is mesocephalic. That is, the growth of this patient is proportional. When it is more than 30, that is, it increases a lot, the cranial base is brachicephalic. And when it is less than 24, it is dolichofacial. And I'm asking, does a patient whose skull base is brachicephalic help the jaw to move forward? Yes or no? On the other side, does a dolichocephalic patient less than 24 make the jaw go backwards or forwards? Backwards, right? This will affect the type of skeletal malocclusion that directly influence the behavior of the maxillary nasal complex and the mandibular versico-skull complex. So it is an angle we have to look, because from what we have seen here and know if we will have a good performance of the cranial base. True? From these complexes starting from the base of the skull, was it understood? The next angle that you are going to see here is the fascial axis, which is measured basium nasion PTB virtual nation. What is the angle? This is, looked here. This is the fascial axis, PTB virtual nation. Be careful. This analysis that you are seeing here is the summarized analysis. This is one of the main angles. There is another analysis that has 27 variables that I'm going to not take in consideration because it's for research. Well, this fascial axis, the angle that is measured is this, the internal angle, which is basium nasion fascial axis. This angle is measured. Okay, let's see how much the angle measures. I put here, I put in the center of the intersection, and this patient is 78 degrees. In his history, and look, it does not change with age, right? And our patient that we just measured, how much does he have? Let's put it here. How much does he have? 78. And if he's 78, what would be our conclusion? Dolic, exactly. We can place facial growth with a vertical predominance of dolichofacial, right? Jaw growth, making all possible decisions for this jaw to rotate, grow, obviously, and go forward in one movement, because the cranial base that is at 30 will allow it. So if this chain goes forward, obviously this 78 is going to improve a lot here.
Excuse me, doctor, I have a question. The cranial deflection, and I kind of got lost here. Brachycephalic dolic, what do you mean? It is not the orientation of the jaw down forward and what you said a little while ago?
Sure, you have a cranial base. When talking about the skull, the term is cephalon. When it comes to the face, it is facial. So we talk about brachycephalic. If we have here, look, I have here the angle. It is the Frankfurt horizontal, and this is basium nasion, which represents the cranial base. Okay? I ask you, Melissa, yes, look here. What if basium nasion starts behaving like this? I'm going to put here, we are going to represent the jaw here. Look what happens when the cranial base increase. 31, 32, 33, 34, 35, 37. Where is the jaw going? Forward and downward. So you have a favorable skull base for mandibular movement? Yes or no?
Yes.
Okay. Now what will happen? Look, if it begins to reduce in size, 29, 24, 23, 18, it is not true that the jaw will always reposition itself. So recognizing how the cranial base is behaving is going to be very important for decision making. Do you understand?
Yes.
If I have a cranial base that is brachycephalic, it is going to be favorable for anterior jaw movement. If it's dolichocephalic, will not be favorable. That patient is likely to be referred for surgery. Do you understand me? So when there are conditions, we can intervene and redirect. We have an element in favor. Okay.
Yes, doctor. Thank you very much.
We have to evaluate the vertical relationship. And for this, we are going to study the angle to which your partner has allowed, which is the angle of the mandibular plane. And that angle, if it changes, as they have said, and it is a plane of Frankfurt with a horizontal jaw, it is normally 26 plus minus 4. And what will happen with this angle it is going to decrease 0.4 per year. Okay, so let's measure it on our patient. In order to make this measurement, you have to make a square, right? Because to get to the horizontal of Frankfurt, we will have to extend up to here, right? But in order not to extend it, we put the main rule on the mandibular plane. Then we take another rule here and make a square. And from here, we move it to the horizontal of Frankfurt. And there we are going to place a line. And that is the angle that we are going to measure. This patient, 38 degrees, and those 38 are recorded here in the angle. There's the 38. What does this angle of the mandibular plane tell us? The angle of the mandibular plane measures the direction of mandibular growth. If the facial axis measures facial growth, the angle of the mandibular plane measures the growth or direction of mandibular growth. And as Dr. Ricketts says here, at the age of 9, the angle of the mandibular plane should be 26 plus minus 4, equal to a range. The normal range will be from 22 degrees to 30 degrees. So we will say that the direction of growth in this patient is proportional. Okay, so they say proportional mandibular growth direction. Of course, if it is close to 30, we will say that it is proportional with a tendency to. Okay? Then, when the angle is greater than 30, the mandibular growth is predominantly vertical. What if it is less than 22? Growth is predominantly horizontal. So, this mandibular plane, the steeper it gets, the bigger the angle is going to be, the higher the angle. That is why these patients who have this high angle number are called high angle. Why? Because they have a predominantly vertical growth. This face is going in this direction, more backwards than forward. Okay? The ones with a smaller angle, look, they have a more horizontal growth, right? Therefore, with higher jaw growth, there is a predominance in the horizontal component. Was it understood? Let's go with the next one. Mandibular Art. Let's go with the mandibular arc. All these angles help us a lot too in diagnosis and treatment. Mandibular arc. What does it measure in practical terms? In practical terms, the mandibular arc that measures us is neuromuscular activity. You know that the muscles leave their mark on the bones, right? And if the muscle leave their mark on the bones, they will also leave it on the angles. What is the angle that we are going to measure? This is it. Look, this is it. GPM in prolongation with GTC. That is the angle. Because this angle is a product of the muscular activity that the levator jaw muscles have on the jaw. Let's see how tall it is. Our patient here is going to have 25 degrees. Yes, indeed, he has 25. We will write it down here in this place. It's 25 degrees. According to Dr. Ricketts, the mandibular arc should be normal at 9 years. It should be 26 plus minus 4 degrees. What about this one? This angle is going to increase 0.5 per year. Okay? 0.5 per year. It increases. But at 9 years of age, we should also have a normal range that goes between 22 and 30 degrees, with 26 as the average. What does it mean to have a neuromuscular within 26 and 30 degrees? You have a normal neuromuscular. He is neither hyperactive nor hypoactive. It is normal. When you have a neuromuscular greater than 30 degrees, you have a strong neuromuscular. This indicates that there is a greater activity of the elevator muscles. It is a patient who closes his mouth very well, has a good grip, who has good activity, while the patient who is less than 22 degrees has a weak neuromuscular. Who has a weak neuromuscular? For example, mouth breathers. Mouth breathers relax the elevator's muscles and increase the depressive activity of the jaw. Therefore, that is going to affect the growth direction of your jaw. It will affect the vertical growth of the jaw, right? So, a weak neuromuscular doesn't help us in the treatment, while a strong neuromuscular can help us, as it can also affect when it is too strong. It doesn't allow the vertical growth of the lower third of the face, right? But indeed, in a neuromuscular within the norm help us a lot to a good behavior of mandibular growth. So this is a detail that we must see. Our patient is about 12 years old and they have spent 3 years here. This should have been increased by 1.5. The mean will no longer be 26, but it will be 27.5 for the age of 12 years. So it will be 25.5 and the range would be -4. The lowest rank would be 23 and the right 31.5. Okay, how much does our patient have? He's 25. So what kind of neuromuscular does our patient have? Normal. Look here. Do you see this little face? Yeah. Are you looking at believe it or not, it is my face. Now watch this. Can you look at the activity of the masseter muscle?
Yes.
Can you look the activity of the temporalis muscle?
Yes.
Where is the masseter muscle inserted? In the gonial angle, right? Okay, that is one. And the pod muscle, is it an elevator or a depressor of the jaw? Elevator, correct. Where is the temporal muscle inserted? In coronate process. Yes, exactly. So both are elevators or depressants?
Elevators.
Okay. If I have a structure that has this shape, an L shape, right? And from the angle, I pull it up, and from the coronate process, I pull it up, right? That jaw or that structure is going to grow like this. Isn't it true? It is going to be stimulated to grow in this way. So if I have here this plane that is CPM and another that is CDC that goes to the condyle of the mandible, if the body moves in this direction, the angle will increase. It's not true. If the jaw grows like this, the angle will increase. Right?
Vertical growth, doctor.
Yes. Then the growth is going to be in both structures. Look, you have here. I'm going to look here. If I have here this CPM, right, that goes to the body, and this one that measures CDC that goes to the condyle, if this body is stimulated to a previous growth, see how much will increase this angle. right? Because precisely, if you pull this structure forward, you will tend to horizontal growth because you have a neuromuscular that allows it. It can adapt easily. If, for example, the first molar erupts, which is a large structure, when it erupts, it makes a kind of premature contact with respect of the primary teeth. What is going to happen? It will act like a fulcrum, right? And if you have a good neuromuscular, you put your jaw here and you automatically do this. And what will you do? When the symphysis goes forward condyle, you are going to follow this path. If it was compressed before, now it is decompressed. And the decompression it causes growth inhibition. So every time your jaw grows forward, CPM becomes more horizontal. And as it becomes more horizontal, the angle increases. That is why this angle is measured to indirectly establish mandibular growth. Okay? So look at how important it is to see these angles to have their correspondence with the craniofacial structure. They are angles that are simply measured. They don't need a lot of science to do it. And now, as you are going to see in the next class, we are going to do it digitally with a program. I want you to learn to draw this, but I need you to be able to join the new knowledge. You find the points and the machine is going to do everything for you. And you just dedicate yourself to interpreting. Okay? Have I explained you correctly?
Yes, thanks.
Okay, so this girl has a normal neuromuscular. It is neither increased nor decreased. She's neither strong nor weak neuromuscular. She's just normal, right? For the 12 years that she has. We already know what use she has. The next point that we have to review here is the anteroinferior facial height that measures the anterior nasal spinal (CPM). This patient has 55 anteroinferior facial height, where it is not here in the angle. What clinical implications does this have for us? If I have a normal lower anterior facial height, I could work within this range and nothing will happen. Why? Because this range tells us that height is normal and the patient's face will always look good within that lower third. But if I have a patient with a decreased lower anterior facial height, I cannot decrease it anymore because the face will be seen in the lower third of the face, flattened. The lips will protrude because the entire neuromuscular is also strong in these patients. In these patients with a decreased lower anterior facial height, it is preferable not to extract because extractions reduce the lower third of the face. And in this patient, it is necessary to avoid extracting first molars, second molars as part of the therapy. Why? Because you are going to decrease the height, and when the height is lost, the back support is lost. And those who are going to be affected are the anterior teeth. Why does it happen that patients' lower anterior facial height decrease? Because he also has a strong neuromuscular. Then the incisors can protrude forward and lose stability. On the other side, when patients have an increased lower anterior facial height, you cannot distalize molars. You cannot make excessive expansive mechanisms. Why? Because they will increase the anterior lower facial height and they will have patients with an exceptionally large height. This within a treatment that what you are looking for is to reach a normal lower anterior facial height, but it may happen that you have to do a treatment within the limits. You have to increase the lower anterior facial height. You will have to approach this value but not increase it anymore. if you have a decreased lower anterior facial height, you will have to get closer to this normal value, but not lower it anymore. Because they are certainly going to see patients in whom you are going to move within those limits, almost to the limit, especially in camouflage when they are surgical patients. And you say, well, I'm going to do it a compensatory treatment, but fundamental is that you understand this, that the posterior support is very important for the anterior guidance. When you are going to pretend to make anterior guides and you have to decrease anterior facial height, you are going to have trouble making guides. And it is even very frequent that you make a decrease in the lower anterior facial height and that you go below the normal range. And it turns out that the patient begins to come with pain in the temporomandibular joint because to compensate for this decreased lower anterior facial height, the incisors are pro-inclinate. And when the incisors are pro-inclinate, the progressive movement is more horizontal than vertical and does not open back, and there are premature contacts on the posterior edge. This is to show the correlation between lower anterior facial height and occlusal physiology. Our task as an orthodontist is that there is good posterior support and that the anterior guides are good. That gives stability. So let's not lose sight of this aspect, and since it does not change with age, this 47 plus minus 4 remains. You know why it is. Let's look at the clinical case. So you can see that all this has a correlation. Let's see how your clinical eye is. Okay, let's see, guys. Look this face. Is it a dolic, meso, or brachy face?
Dolic, doctor.
Correct. Is the facial height in this patient increased or decreased?
Increased.
Is the lower third of the face in relation to the middle third increased or decreased?
Increased.
Perfect. You are doing it. You are doing a clinical diagnosis. And seen like this, in this profile, you can see the increase in the lower third of the face?
Yes.
Would this face increase the lower third of the face more?
No.
Okay. Notice this girl was having expansion and distalization of the upper arc and the lower arc. So she worsens her profile, right? Yes, look here. Here is the expander and distalizer, and more lower teeth are going to show. Besides, this girl has a prominent nose. Look, you take that jaw lower, and when she leaves your office, she's going to go straight to a tree. She's going to be crushed like an arrow puck because her nose is going to be prominent, very prominent, right? This face cannot, in any case, continue with a growth of the lower anterior facial height. This patient came because notice how the molar had also been expanded with the appliance, and we had said that when the molar is vertical, the height will increase. The distalis will increase the height. And surely the orthodontics here was working with a very good intention of not extracting teeth. But he was looking at nothing but teeth, because she would look and say, how am I going to do extractions in this case? He looked and said, I can grab here and protrude a little here, but notice two huge things here: long face, a large lower third, and extremely steep occlusal plane. Looking only at this structure, right? And another thing, it has a class 2 craniofacial growth pattern with a rotational growth of the nasomaxillary complex. We did cephalometry. Look the cephalometry, and how tall she was in the anterior inferior facial. How much does she have? 57, 1 centimeter more. How tall is it? 75. Does it look like our patient? Look, 25, 30, 73. Are you seeing it? they look similar. These patients, if you are not careful, can develop an open bite. The occlusal plane is above she, right? We did a VTO precisely controlling the growth of the molar, changing the occlusal plane and all that to look for a rotation. You will see all this here. Here's the X-ray, and look, this is the vertical control that we installed. We did a treatment with extractions because we know that this patient is going to require space, right? And we are going to extract upper first and lower second premolars. I think that was the treatment. Let's see. We aligned, we leveled. Look at this transpalating arc. Do you see it? It is a thick transpalatal arc, separated 5 millimeters from the palate. For what? To make vertical control of the molars. This one here is from the extraoral arm. You have seen the extraoral, right? That thickness.
Does this patient use extraoral for vertical control, doctor?
No, she doesn't use headgear because the patient didn't want to use appliance.
But can and should it be used?
Sure, I could have used headgear with her, right? And with vertical control.
High traction, doctor?
Let's see. Not high traction, because high traction is going to cause more of a molar to be intrude and the closal plane doesn't change. Here I have to inhibit the growth of the molar, but at the same time, the omega must be forward. For what? So that you can rotate the occlusal plane of the molar and flatten it. Don't steep it. So here I have the tongue as an ally. The tongue in this patient was marked, so I have a force coming from the tongue that prevents the growth of the molar. And look how the bite closes. And see here. What piece have I extracted in the lower one?
The second, doctor.
Right. What do I want? I want to mesialize the posterior sector. Take it forward. What happens when I mesialize the posterior sector forward? Does the fascial axis close or open?
Closes.
And does the anterior-inferior facial height decrease or increase?
Decreases.
Yes. See how important the decision making in this regard was. There it is. And so that they do not go backwards, we use this attachment called bite fixer. The bite fixer acts as an anchor. And from this anchor, mesialize the molar here. Look. We finish the case with this patient. This patient ends as you are seeing here. Here is her third molar, which we then send to extract. That will also help a lot to complete the treatment. Here it is over. Her growth ceased. And her growth was over. And look at the change we have made. Look where the closal plane is. She's at the height of she. She's a patient who no longer had growth, right? As we had no growth, we could only work on the occlusal plane. Look at the occlusal plane here. It is steep and here it is flat. You're going to see the cephalometry here. Look here. Do you see how the occlusal plane is here? It's steep, right? Look how the occlusal plane is here, below she. And if this was 57, now it's 55. But this change of the occlusal plane was achieved with transpalatal arc, doctor? What the transpalatal arc does is to inhibit that molar from extruding. Yes, and it also changed the direction. Here you have a dolic molar, and here you have a mesomolar. What do I mean by dolic and meso? I mean this. Here it is. Okay. Look at the axis of this molar. And look at the axis from now of this molar. When one has a molar like the one you are seeing here, it is at the level of the strong zygonomatic. This molar is a highly stable molar because the energy that is in this tooth when chewing will be directed towards the orbit and the zygomatic, and this will have a strong favorable influence on the limbic system and tonsillar, which has to do with the emotions. That is why these people feel much calm, less emotional. When this molar is like this, directing all their energy towards this area, they irritate the limbic and tonsillar areas. Here it is balanced because all energy goes directly to the buttresses.
Have I achieved that with transpalatal arc, doctor?
Yes, of course, with the transpalatal arc separated by 8 millimeters from the palate. And the extractions were to close the anterior inferior facial height. Doctor, this patient was no longer growing. Exactly, that's why we are doing. Oh, look here. 2 years later, she came to do her check. Here she told me, Doctor, can I operate the nose? Of course. So you can operate the nose. Look at the occlusion. Just as we had left midlines, overjet, overbite, interdigitation. 3 years later, that is 5 years after finishing the treatment with another camera. Here I was testing my digital camera for that time. Look at all the right interdigitating. There was stability in the mouth. Did you understand me? And when you apply this concatenated with technology, you will see how easy it is to do orthodontics when you know what the patient has. Nice to have you today. Thank you. Bye-bye, everyone. See you in the next class. Bye.